Hi Dr. Azlin and everyone, we are from Group 2. In this presentation, we will focus on a case of traumatic brain injury, a condition that affects each patient differently in terms of function and recovery. To guide our assessment and intervention, we apply the principles of patient-centered care, which ensure that treatment is tailored to the patient individual's needs, values, and goals. And here is our group members. Let's talk about the patient-centered care or PCC approach, a healthcare model that truly puts the patient first. It focuses on the individual needs, values, and preferences of the patient. Instead of just treating the disease, it sees the patient as a whole person, physically, emotionally, socially, and culturally. Recognized by the World Health Organization (WHO), PCC is a key part of high-quality healthcare. It promotes strong partnership between patients and healthcare professionals to boost satisfaction and deliver better health outcomes. This approach, firstly, respect and responds to what matters most to the patients. Secondly, guide every clinical decision based on patient value. Third, build strong partnership and collaboration. And most importantly, improves outcome by creating more satisfying and meaningful care experience. Let's explore the four key principles of the patient-centered care approach, a model that puts the patient first, not just a case or condition, but as a whole person. First, we begin by exploring the patient illness experience. This means truly listening to the patient's story beyond the symptom and understanding how the condition affect their daily life. Second, it's about understanding the whole person in context. We care not just for the body, but also the mind, emotion, and social needs while respecting their culture, background, and lifestyle. Third, we focus on finding common ground. Healthcare decisions should be shared between patient and provider. We build a true partnership where patients are encouraged to actively participate in their own care. And fourth, we work on enhancing the patient and healthcare relationship. Care should be personalized and goal-based, aligning with what truly matters to the patients, helping them live the life they want. In summary, patient-centered care is about putting the patient first, not just a case or condition, but as a whole person. Now, we will show how patient-centered care (PCC) is applied in managing traumatic brain injury (TBI). TBI patients often face physical, cognitive, and emotional challenges. PCC encourages us to listen the patient's full story, not just focus on the injury. For example, issues like memory loss, mood swings, or social difficulties must be considered as part of their care. Next, PCC emphasizes understanding the whole person, their age, culture, family role, and personal goals. For example, a student may need help returning to class, while an adult might need support to go back to work. PCC also helps us find common ground. We involve the patient and family in decision making, which increases motivation and improves outcomes. Lastly, we focus on enhancing the patient and also the clinician relationship by setting meaningful goals like returning to parenting or independent living. This builds trust and supports recovery in a way that truly matters to the patients.
Next, we'll look at the characteristic of a patient-centered approach for TBI patients. First is individualized care plan. Each TBI patient has unique needs. For example, one may have memory loss, another may have balance problems, so plans must be tailored to each patient's specific goals and abilities. Second is shared decisions making. TBI patients and their families help set goals and make decisions. This restores a sense of control and keep them motivated. Third is interdisciplinary teamwork. TBI affect many areas: movement, speech, emotions. A coordinated teams, including physiotherapists, psychologists, and social workers, works together to address all needs. Fourth, respect for values and culture. Rehabilitation should respect the patient's cultures, beliefs, and family dynamics. This helps build trust and improve cooperations. Fifth, focus on functional goals. Instead of only treating symptoms, rehab should target real life activities like self care, work, or social roles. Sixth, family and caregiver involvement. Families play a major role in daily care and reminders, so they should be supported and educated too. 7. Continuity and coordinations. Smooth handovers from hospital to rehab to home prevent gaps in care and support long-term recovery. Now we continue with the main benefits of applying this approach to TBI patients. First is better functional outcomes. Patients regain independence in daily tasks faster when care is personalized. Second is higher satisfactions. Patients and families feel heard and respected, which build trust. Improve adherence. When patients have set goals, they are more motivated to attend therapy and practice at home. And it also helps to enhance quality of life. This approach addresses not just physical issues, but also emotional and social needs. And then reduce caregiver stress. Involving and educating families reduces misunderstanding and burnout. It also helps to lower risk of complications. Coordinated care lowers the chance of false hospital readmissions or secondary problems. And last, it promotes self-management. Patients learn how to handle memory lapses or fatigue, which help them live more independently.
Let me introduce the case of Mr. Tan. Mr. Tan is a 45-year-old senior accountant who sustained a moderate traumatic brain injury or TBI as a result of a road traffic accident that occurred 3 months ago. Since the injury, Mr. Tan now presents with several neurological and functional challenges. These include right-sided weakness, balance difficulties, and mild cognitive deficits. In addition, his family has observed increased fatigue and irritability, which are common post-TBI symptoms. Our subjective assessment is guided by the principles of patient-centered care, which emphasizes Mr. Tan's unique experience, concerns, and goals. We begin with demographic information. Mr. Tan is a 45-year-old male working as a senior accountant. His injury occurred 3 months ago following a road traffic accident. This demographic and injury information establishes a baseline and helps guide age-appropriate rehabilitation while also supporting return to work planning. Next, we consider Mr. Tan's presenting complaints. In his own words, he says, I feel weak on my right side. I lose balance easily when walking outside. I get tired fast and sometimes I snap at people without meaning to. And I want to go back to work and start playing golf again. These statements reflect his physical, cognitive, and emotional challenges while also revealing meaningful goals. Understanding these patient reported concerns is vital for aligning therapy with his personal values and prioritizing care effectively. Next, we look at the history of present illness. Mr. Tan was hospitalized for 2 weeks and underwent inpatient rehabilitation. Since then, he has been experiencing right side weakness, mild cognitive issues, emotional lability, and fatigue. He is currently attending both physiotherapy and occupational therapy weekly and has no recent seizures. This section helps identify the neurological and functional consequences of TBI, which are crucial for safe and targeted intervention planning. Next, we find out about the medical and surgical history of Mr. Tan. He has no known chronic illnesses such as diabetes or hypertension, and there are no previous neurological or orthopedic conditions reported, and also there are no surgical history related to the current injury. Additionally, he is not on any medications that affect his rehabilitation process. This information is essential in identifying any pre-existing conditions that could influence or complicate his recovery. Moving on to social and occupational history, Mr. Tan lives with his spouse and two teenage children. He has a supportive family, although they have expressed concerns about his fatigue and increased irritability since the injury. In his leisure time, he enjoys playing golf and hopes to return to it. Professionally, he is a senior accountant in a finance firm. He is currently on medical leave, but is actively planning to return to work. Understanding these social and occupational factors help us tailor rehabilitation goals to his lifestyle, responsibilities, and support system. Finally, let's look at Mr. Tan's goals. In the short term, he wants to improve right hand coordination for daily activities, enhance his balance and walking confidence outdoors, and manage fatigue better throughout the day. His long term goals include returning to work in his role as a senior accountant, resuming recreational golf, regaining full independence in daily living, and improving cognitive clarity and emotional regulation. These goals guide the rehabilitation process, ensuring it remains meaningful, realistic, and aligned with what matters most to Mr. Tan. This comprehensive understanding of Mr. Tan's history and goals allows for a more personalized, effective, and patient-centered rehabilitation plan.
For objective assessment, we look for the observation, which is the general and local observation. For general observation, Mr. Tan is visual 4, conscious, cooperative, and fatigue. But for the local observation, Mr. Tan is slightly stoop posture with mild asymmetry and reduced tenderness movement on the right side of the body. Second objective assessment is the vital sign. We need to measure the vital sign before we start any assessment and exercise. So for Mr. Tan, the data is all normal. Second objective assessment is the vital sign. We need to measure the vital sign before we start any assessment. Next is manual muscle testing. For Mr. Tan, all other movements are normal except the wrist flexion and ankle plantar flexion. Only score 3/5 and 2/5. And then for the grip strength test, left is 52 kg and right is 30 kg. For muscle tone, we follow the modified Ashford scale. For Mr. Tan, data is 1 for right wrist flexor and ankle plantar flexor. Next assessment is the coordination. We perform the finger to nose test. We found that Mr. Tan had weak and difficult in right hand. For the balance test, we perform the static balance and dynamic balance. For the result, we found that Mr. Tan is poor in dynamic balance, especially reaching. Next is the gait observation. We observe that Mr. Tan has low gait speed, reduced right step length and stride length, reduced right arm swing, and circumtension of the right leg during the swing phase. Here is the analysis from the objective assessment just now. Mr. Tan had right side weakness the left side due to TBI affecting the left hemisphere. Low muscle strength at wrist flexor and ankle plantar flexor due to increased muscle tone. Muscle tone increased due to spasticity. Poor grip strength due to muscle weakness. Poor coordination due to damage to the frontal lobe. Poor dynamic balance due to fear of falling post-injury. Circumduction gait due to mild foot drop. For the short-term plan is to improve right lower limb strength to reduce foot drop, improve balance to reduce fall risk, increase grip strength in right hand, reduce spasticity in right wrist and ankle to improve the functional movement, improve coordination for daily tasks. While for the long-term plan is to regain self-independent community ambulation, return to work with improved cognitive motor control, safety return to recreational activity like golf, improve overall endurance and reduce fatigue after activity. For the first intervention, we focus on the strengthening and stretching exercise. We focus on the wrist and ankle. Use dumbbell for wrist flexion, extension, inversion, and eversion, and then use TheraBand for the ankle dorsiflexion and plantar flexion. Each strengthening exercise do for 10 repetitions as 1 set and do for 3 sets. But for the stretching exercise, we focus on the wrist flexors and plantar flexors, do for 30 seconds for 1 set and do for 3 sets. Second intervention is balance exercise. First, dynamic balance. Ask the patient to reaching in standing and multi-directional stepping, 3 repetitions per set and 3 sets per day. Second is dual task training. We can ask the patient to counting while walking, for example, count 1 to 100 as 1 set. The last intervention is gait training. We can use footstep sticker to focus on the step length and symmetry. Here is all our reference. That's all from us. Thank you.